Before we start to give you the concern over safety, it's very clear message. Don't use LABA alone. LABA cannot be used as monotherapy. It is add-on therapy. It has to be used as add-on on steroids. But to give LABA alone, there are many concerns about this. And we will show you some of the studies. This is FDA. They said that LABA can occasionally worsen the symptoms of an asthma attack. And they recommend, the FDA, that it should not be used as the first line treatment because the first line anti-inflammatory is steroids and are not suitable for the treatment of acute asthma attack. Why? Acute asthma attack, the first thing to start is the steroids. But LABA will take time to start, and it is not anti-inflammatory. So you cannot use in the acute attack LABA. It is add-on therapy, but it is not the first line. It's very clear message. Should not be stopped suddenly without medical advice. This is a smart study done in 2006, salmeterol multicenter asthma research trial. They found that salmeterol, if used alone, it can increase the rate of death. It's a very clear message to you. And they said that this mortality increases when the LABA will be used alone. So this effect was greatest in those who do not establish on inhaled steroid preventer therapy, in those who use LABA alone without steroids. So you can imagine it can increase the mortality. So it's not a game. Don't give LABA alone. This is another study in 2006 by Wolf. It showed there were more adverse events in the group of patients not receiving concomitant anti-inflammatory treatment. So you have to add it on steroids, not alone. And now we have very fantastic, actually, inhalers which are containing LABA and steroids like Seretide and Symbicort. So it is not licensed very clearly as monotherapy and not recommended for the use in the treatment of acute severe asthma as the first line. So it is not a monotherapy at all. This is by guideline BTS and SIGN. They said that does not recommend the use of inhaled LABA unless an individual is already established on inhaled steroids. It's a very clear message for you. So remember, LABA cannot replace steroids as the first line preventers. First line preventer is steroids. The use. It is to be used regularly, twice daily, as maintenance therapy, but not as the first line. We keep repeating the same thing again. It is the first line preventer is steroids. And it cannot replace steroids. LABA are not replacement for established prophylactic agent used in addition to them. It is the first line add-on therapy in step 3 in the guideline. They are the first choice for add-on. Add-on meaning that you start a steroid, then you add above that the LABA. What is after LABA? If you don't succeed, Eltras. After that, methylxanthine, and at the end, the slow-release beta-2 agonist tablets, Bambeck. Salmeterol is licensed after 4 years. Below 4 years, because we don't use salmeterol alone. We use it with steroids. But if you want to give separated inhalers, you give salmeterol like an example, and you give with salmeterol steroids. Okay? But it is used to be used because there is a problem of the safety. You use it over 4 years. Foradil is to be used over 5 years. Formoterol is to be, or Oxys, over 6 years. And we said that formoterol is different from salmeterol. Formoterol will act directly, so it can be used for relief of breakthrough symptoms of asthma. These are the nice drugs which are the combinations. The first one is Seretide, which is a combination of salmeterol and fluticasone. Okay? And it's nice to give it because you give LABA with steroids. Seretide, this is Acuhelep, Seretide, and these are MDIs. The difference in the drugs is in the steroids, but salmeterol is almost constant. Beta-2 dose is constant in all, but the change is in the steroid dose. So salmeterol is fixed strength, but fluticasone is the one which vary from 50 to 250 microgram. And these are some of the terms. This is 100 to 150. The difference in the steroids. 500, very high dose. This can be used for adults. 250, this is inhaler, and this is apohaler or discus. Okay, this is the discus dry powder, 100 microgram strength, and 50 microgram MDI are licensed for children over 4 years. The other combination is Symbicort. Symbicort is containing two drugs, LABA and steroids. It contains formoterol and budesonide. And we said the same. The difference in the doses is in the steroids, but formoterol dose is constant. These are some of the forms of the Symbicort. This is 400 steroid over 12 LABA, formoterol, and this is 100 steroid over 6, and this is 200 over 6. And Symbicort is to be used over 6 years. The highest dose can be used in adults, of course. Combination therapy, side effect exactly, if you talk about the LABA, it's the same, and used for individuals who require treatment with both an inhaled steroid and long-acting beta-2 agonist. Clinical use. Of course, there is a question here that, do you advise to use them alone, I mean beta-2 agonist and the steroids, or you advise, not myself, the evidence advice to use the combination from the start. For practical points of view, it's better to prescribe the combination, and for the compliance of the patients, it's better to give the combination from the start. But if you give them separated, it will give the same action. There is no difference, but it's better for the patient to avoid to carry two inhalers, and they will start to ask, what is this and what is that, and sometimes, like what we say yesterday, that they will be hesitant to take steroids. No, give combination from the start. It will be better. And the cost will be cheaper also. So now it is very clear about LABA and beta-2 agonist, the short-acting. Anticholinergics. Anticholinergics now are out of the guidelines, except if you use the anticholinergic in the nebulizer in addition to beta-2 agonist. Okay? Why? Because the most famous one is atrovent. Atrovent will start the work after half an hour. So how it can be used for the relief of acute symptoms? Beta-2 agonist will be better than it. Because of that, if you go to the guidelines, you will not find any anticholinergics. So it's clear to you now that anticholinergics are used mainly in the acute asthma, in nebulizer, with addition to beta-2 agonist. In addition to, with the beta-2 agonist, it will give a better response in relieving the acute asthma attacks. There are several types, MDI, nebulizer solution, dry powder, and this is the long-acting anticholinergic tiotropium, which is used in COPD more than asthma. And usually, we know it is antimuscarinic, it will inhibit the vagus, and the problem that the action will start after 30 to 40 minutes, so it is very slow in doing the action, and it is not that useful in the acute attacks. The side effects are anticholinergic, mainly dry mouth, nausea, constipation, headache. Okay, clinical use. It is well known that if you use it by inhalation, if you use face mask, this is found in the evidence. If you use it with the face mask, it will go to the eye and it will cause acute angle closure glaucoma. So it's better in the evidence if you use it with the beta-2 agonist, use the mouthpiece, okay? Better than using the mouthpiece is better than using the mask, because it will cause acute angle closure glaucoma. So now in the evidence, guideline found insufficient evidence to support the routine use of anticholinergic drugs in asthma management. It is out of the guideline. We said, just to say this word to you, except in the acute attacks. In acute severe life-threatening asthma, combination of nebulized ipratropium and salbutamol, and please give it by mouthpiece, not by mask. It will be good in relieving the acute attack, especially in elderly, by the way. Methyl